Thank you very much for the invitation. We're supposed to talk about women in GI, and after discussion with some colleagues, they prefer to speak about pregnancy. So today's objectives that we'll speak about pregnancy with hepatitis C and hepatitis B infection. Also, we are going to approach the benign liver lesion in pregnancy, and we will touch on liver cirrhosis during pregnancy. We'll start with hepatitis C during pregnancy, and there is adopted screening program for hepatitis C in the country by majority of the authorities. However, there are still some areas where the screening for hepatitis C during pregnancy is not adopted. And to know if we need screening, that we have to know the prevalence of the disease in the region. And there is no published data from UAE about the prevalence of hepatitis C during pregnancy. However, if we will look at the prevalence of the hepatitis C in pregnancy in Saudi Arabia is 0.7. And that may give us some idea about our risk. It could be a little bit less than that. However, it is just estimation. And if we promote for screening for hepatitis C in the country, we have to know that it is cost effective or not. And if we look at this diagram, this is the line where is the cost of the procedure, and here is the prevalence. If the cost of the procedures goes down, this means that the procedure we are doing is cost effective. And we see the line actually drop down at about 0.04. And if our prevalence is about 0.5, 0.6, so our screening program for hepatitis C during pregnancy is actually cost effective. And during pregnancy, what is the effect of pregnancy on hepatitis C? As we can see here in the diagram, the gray area is the ALT level, and we notice that ALT level normally will increase in the third trimester, and it will also in the after delivery in the postpartum area. In the same time, the level of hepatitis C will increase in the third trimester and drop down at the time of the delivery. Also, if you notice these interrupted lines, these are the cytokines, and often the cytokines normally will increase in the third trimester, preparing the woman for delivery. And if this woman is lucky, there will be an interaction between the cytokine and the hepatitis C virus, and the lady will have 10 to 25% chance to clear the virus. What about hepatitis C impact on the pregnancy, the mother and the fetus? We all know that pregnant women with hepatitis C has a high risk of intrahepatic cholestasis with the odd ratio of 20.40. This means the pregnant woman with hepatitis C likelihood to develop intrahepatic cholestasis 20 times more than regular women. And what about the effect of hepatitis C on the fetus itself? There is also increased risk of preterm birth by 1.62, increased intra-growth retardation by 1.53, and the low birth weight by 1.97. And of course, if the patient is having cirrhosis, there will be much higher risk for the mother and the fetus with poor prognosis. And we talk about the transmission of hepatitis C from the mother to the fetus. And if we look at this line is estimated the risk of transmission falling down to just after 5 at 5.8%. So risk of hepatitis C transmission from mother to fetus is 5.8. And always we are looking for a method to reduce this risk, and we are looking what things can make this risk worse. So the next slide will look at this procedure, which is common during pregnancy or at delivery time. And cesarean section, always the question, is it going to reduce the risk of transmission, or is it going to increase the risk of transmission? We have about 4 and 11 studies, and all has shown that there is no association between cesarean section and risk of transmission of the virus. So vaginal delivery is equal to cesarean section in terms of risk of viral transmission. They looked also about internal fetal monitoring, where they have to put the catheter in the scalp of the fetus. And they did 3 studies, and the result, 2 of them said there is no increased risk. However, there is 1 study which suggested that there is increased risk of viral transmission. Therefore, actually, in the practice, they are minimizing the use of intra-fetal monitoring for hepatitis C positive mothers. And for the premature rupture of the membrane, there are 2 studies which had been done, and both of them showed there is increased risk of viral transmission if the delivery happened after 6 hours from the rupture of the membrane. Therefore, always these patients will be taken for more immediate delivery method, not to exceed the 6 hours. And the breastfeeding, several studies done on, and it's pretty safe. There is no increased risk of transmission with pregnancy, with breastfeeding. So there is no procedure you can do to reduce the risk of hepatitis C virus transmission, and breastfeeding is actually a safe procedure. What about treatment of hepatitis C in pregnancy? Definitely we all know that there is not much of data to support the starting direct antiviral therapy during the pregnancy. And there are some studies, which is small case series or small pilot study. This is a study of 9 pregnant women where they give them lidipase phosphobare for 12 weeks. It started in the 2nd trimester from 23 to 24 weeks of gestation. All of them did well during the pregnancy. 5 of them had very minimal side effects like nausea, vomiting, diarrhea, fatigue, and that did not affect the mother or the baby. And they all had cleared the virus and they achieved SVR12. There is another case series where they gave the same lidipase phosphobare for 15 pregnant women in the 2nd trimester, and all had been doing well during the treatment and after the treatment, as well as does the fetus and the neonate, and they achieve SVR at 12. However, before we can commence the pregnant women for hepatitis direct antiviral therapy, we have to find much bigger research and data for that. We move now to hepatitis B, and the prevalence of hepatitis B in UAE is about 1.5%. And the risk of transmission of hepatitis B from the mother to the fetus is very high, 95%, as we all know. And the impact of the pregnancy on hepatitis B is pretty negligible. There is no interaction between them. However, there is a chance of ALT flare, but mainly in the end of the pregnancy or after delivery. And the hepatitis B flare is documented by increasing the ALT greater than 300 or 200, and this can occur in 3.5 to 25% of the patient, mainly after delivery when the immune response change, or after the patient discontinued treatment if she was on during the pregnancy. So how we can do hepatitis B prophylaxis for a pregnant woman with hepatitis B? After delivery, we all know that the baby or the neonate should receive the hepatitis B immunoglobulin and the hepatitis B vaccination within 12 hours of birth. And there are data suggest that increased risk of transmission if the dose of the immunoglobulin has been delayed more than 12 hours. Also, the vaccine that we give, the patient should continue at the regular schedule of after 1 month and 6 months for the neonate. And during the pregnancy, we all depend on the viral load during pregnancy. If it is greater than 200,000 or 1 million copy per liter, then we have to initiate the antiviral therapy if the mother and the husband agreeing on the medication. So what medication we have? So in our pharmacy, we have lamivudine, tenofovir disoproxil, tenofovir alfonamide, and entecavir. And lamivudine, it's very safe during pregnancy on the mother and in the fetus. And the only issue it has is only the increased risk of resistance. And tenofovir disoproxil, we have so many studies, and it had been safe on the mother, on the fetus, and during lactation, and it has no resistance. That's why it is widely used. In terms of the new version of TDF, which is TAF, we have insufficient data to be started as routine for all pregnant women. However, the data that we have is 120 patients who was pregnant started on TAF, and they had very good result, and it was very safe. And entecavir is the same, just because the sample of the study was not adequate, so it was not recommended. Otherwise, we see in real practice many women on entecavir that continued on the treatment. So we'll move the next to benign liver lesion during pregnancy. And we all know the commonest benign lesion we have is the hemangioma, the focal-nodular hyperplasia, and the adenoma. And always the concern whether they are related to the hormone during pregnancy, which is the estrogen. And we know hemangioma does not be influenced by the estrogen, so no monitoring needed. Very extremely rare that you will see a patient with cavernous hemangioma, that size is more than 10 centimeter with risk of rupture, that it will need a monitoring. Focal nodular hyperplasia is not influenced by the estrogen and does not need any monitoring during the pregnancy, and the diagnosis is by images. The adenoma or hepatocellular adenoma is very sensitive to estrogen, and usually the size does increase gradually during pregnancy or even with oral contraceptive pills, and this will need monitoring. So when you monitor it, if you know the size of the hepatocellular adenoma at the time of the pregnancy, less than 5 centimeter, monitor it during pregnancy every trimester with ultrasound. If the size is stable, that's okay, nothing to be done, just continue monitoring. But if the size increase more than 5 centimeter, you could consider blunt embolization, transarterial embolization of the lesion. And if the size from the beginning is greater than 5 centimeter, you could consider the embolization or surgical resection. Now, embolization of the lesion, it does have its own risk on the mother and in pregnancy, but it's not very high risk if it was used with highly selective arterial approach. What about liver cirrhosis in pregnancy? For liver cirrhosis, there is increased rate of pregnancy nowadays with advanced medicine that we can see with patients who have cirrhosis, much more than before. And there is a comparison between the incidence of pregnancy with cirrhosis jumping from 2.5 to 6.5 over a course of 9 years. And there is morbidity and mortality associated, and which is very significant for the mother and the fetus, which is more than the non-pregnant cirrhotic patient. There is a risk of death for the mother and also the risk of stillbirth for the baby. And the outcome of the pregnancy with cirrhotic mother, there is an adverse event on the mother, and there is increased risk of gestational diabetes, increased risk of hypertension during pregnancy, the need for cesarean section, and the postpartum hemorrhage. And there is also a very high risk of preterm birth. Most of them will have preterm birth with liver cirrhosis. And the most important part why I present this is how to deal with varices in these patients, especially in the mortality rate which is associated with variceal bleeding during pregnancy is 5 to 8.5% in the pregnant woman with liver cirrhosis. And it is considered associated with 18 to 20% mortality rate, which is very high. And usually the bleeding risk is happen in the second trimester of the pregnancy, because in the second trimester the volume of the plasma will increase and the gravid uterus will start to compress on the IVC. That's why the portal hypertension is higher and risk of bleeding is high. So if the patient is having cirrhosis planned for pregnancy, we better deal with the varices before getting conceived or having pregnancy. If you find her at this stage, you do EGD and you follow the same procedure what you are doing for a regular individual. However, you will be more keen to start band ligation if it is large varices, even if the Child-Pugh score is not suggestive for that. And if the patient did not come before pregnancy and you are seeing her during pregnancy and she has liver cirrhosis, you start screening EGD at the second trimester. And during the second trimester, if they are small varices, then you see non-selective beta blocker, and if they are large varices, you go for band ligation and obliteration. And the important thing to remember that when you are doing general anesthesia, the preferred anesthetic agent are the fentanyl, meperidine, midazolam, and propofol. And always remember there is another fetus that has to be monitored continuously during the procedure, and there is increased risk of mental issues related to the sedation for the fetus, brain damage and impairment if the procedure took more than 3 hours, or if the patient require more than frequent procedures or require sedation in the third trimester. So by this, I conclude my session, and I would like you to remember that the hepatitis C virus, you have no procedure to prevent or decrease the risk of transmission, and breastfeeding is safe for this group of patients. And the hepatitis B immunoprophylaxis, the timing is very important, and remember the antiviral therapy during pregnancy. And always remember that we need to interfere if the patient has liver cirrhosis with screening in the second trimester and band ligation if they are large, and be careful about the duration of the procedure. And the hepatic adenoma always require monitoring with the ultrasound, and if the size more than 5, you may have to interfere. Thank you very much.